Hello, I'm Umair Khalid. I'm one of the social media editors at JACC Cardiovascular Interventions, and it's my great pleasure to welcome Dr. Shwamenthal and Dr. Pinto for a conversation for their latest article. Thank you so much, both of you, for joining us today.
Thank you for having us.
We are very excited to feature your publication titled High Output Mechanical Circulatory Support in Left Main Interventions, the Magenta Elevate High Risk PCI First in Human Study. So could you please begin by introducing the Magenta Elevate device and its implantation technique for the audience?
Thank you, Dr. Khalid. Dr. Shwamenthal, I think, will be sharing his screen here, and you can see the Magenta Elevate system is comprised of several components: the controller, an overtube through which the pump is delivered, and you can see it is advanced in a collapsed form, which is 10 French outer diameter, fits through, as you can see here, 10 French off the shelf sheath. The pump is advanced across the aortic valve and deployed inside the ventricle, where the 30 French pump then moves blood from the left ventricle through the microaxial flow pump into the aorta. And this is performed after the controller is attached, as you see, and the blood moves at a mean flow of greater than 5 liters. This is fluoroscopically demonstrating the same thing that you just saw in the animation, and the pump is advanced into the left ventricle and then unsheathed and begins function. You can see the details of the PCI here. In this first-in-man study, these were multi-vessel left main interventions, and you can see that these were all done successfully.
Thank you. This is a very nice animation and the fluoroscopic view to explain the device. So my next question would be about the key findings of your study. If you could explain that for the audience.
Sure. So the first-in-human study comprised 14 high-risk PCI patients, which were supported with a Magenta Elevate. Safety outcomes, the primary safety outcome was the absence of major device-related adverse event, and there were none. There was one groin hematoma, which did not require any intervention, and there was no mortality at 30 days. Now, importantly, while in the first patients we used a 3.5 liter flow device, we used a high flow device in 9 of them, 5.4 liters per minute mean flow. And this enabled us in 8 patients who had an unprotected left main intervention to perform prolonged balloon occlusions. And you can see in the lower left hand picture the hemodynamic result. So interestingly, even with a background flow of 3 liters per minute of mean flow, there was immediately a striking increase in left ventricular filling pressure and a drop in aortic pressure when inflating the balloon. And when increasing the pump flow, this could be corrected. That is, the filling pressure decreased and the mean pressure remained fairly in the normal range. And we achieved a degree of unloading, which is called uncoupling. That is, you can see that the left ventricular pressure curve detaches from the aortic pressure curve. So the aortic valve is now closed and the complete cardiac output is carried by the device. So despite a significant drop in systolic aortic pressure, mean aortic pressure remained in the normal range. And importantly, the diastolic aorto left ventricular pressure difference, that is the myocardial perfusion pressure, which drives also collateral flow, remained absolutely constant. So I think that's the gist of the findings.
Thank you, Dr. Shwamenthal. That's very helpful. Now, moving on, I can't help but compare it with the Impella CP device, which is obviously a very commonly used device currently for high-risk coronary interventions. And it has, in some way, a similar design to Magenta Elevate as well. So it would be great if you could elaborate on some of the differences. I know the reduction in the sheath size is a great plus, but what about other differences?
Sure. So in order to do so, I would like to show you basically a core feature of the technology. and that is that there is the impeller is basically comprises a helical nitinol frame that can be completely folded. In other words, the impeller itself, not just the pump housing, is fully self-expanding. And this sets it apart from all other competitors, which use basically impellers that are cast from one solid block. And in that case, the only way to crimp it would be to wrap those flap wings around the rigid core and then compress. And that leaves you only an expansion ratio of a little bit more than 2. On the other hand, the Elevate system does not only afford a great degree of miniaturization, but also allows to expand to a large pump, which means that there will be a high achievable flow rate. And I've put this together in this comparison table, and you can see here the mean flow is 5.4 liters per minute at a relatively low revolutions per minute if you compare this to the other devices, with a peak flow in systole of 8.4, and it therefore compares even favorably to the impeller flagship, the impeller 5.5, which has actually 23 French proprietary introducer and requires a surgical cut down. So that would be one comparison. Compared to the CP and the ECP, it also provides a greater mean flow at a lower RPM, and it has a few additional advantages. First of all, as you could see in the animation, it is delivered fully over the wire and sheath. In contrast, for the impeller ECP, there is no wire, so sometimes one would need a body catheter, and that means a second access in order to place it. And the impeller ECP also needs to be delivered open across the arch and valve, as it is basically pops out in the descending aorta. A common feature with the ECP is the collapsible sleeve, which is very important. You've seen in the animation that it remains collapsed, and therefore there's no aortic regurgitation when the pump stops or is not yet activated, which makes it very safe. So in summary, I would say the high output device at a low profile makes this a device which could be ideal for cardiogenic shock, advanced heart failure, and use an extensive anterior wall MI, for instance.
Dr. Khalid, too, just as a small technical point, the 10 French off the shelf sheath, we were able to close this with the standard techniques that we're all used to. Pre-close, post-close, and a French angioseal were all used either individually or in combination.
I see. That's actually what I was just thinking as well. And this is a great comparison, Dr. Schaumantel. Thank you both again for sharing these insightful results with us, and congratulations on your work.